Good evening, everyone. So on behalf of IASTA, firstly, we wish to thank Dr. Kalpana for accepting our request to deliver this lecture despite her very busy schedule. Dr. Kalpana is working as a dean at SRUICMR. And okay, it is my privilege to introduce Dr. Kalpana Balakrishnan. Dr. Kalpana earned her undergraduate degree from All India Institute of Medical Sciences, New Delhi, and subsequently she had her doctoral and she went for her doctoral and postdoctoral training at Johns Hopkins University, USA. She is a leading global environmental health scientist in India, spearheading research and academic efforts in the areas of health effects of air pollution and chemical risk assessment. Her primary scientific contributions are centered on developing novel exposure assessment approaches to characterize the complex exposure experienced by rural and urban population in LMICs, and designing and conducting strategic epidemiological investigation in India to catalyze policy level actions by leveraging across the national and global pools of evidence. Her high impact publications have been extensively cited. Her papers have about 89,000 citations with H-index of about 68 as per Google Scholar. In 2020, 2021, 2022, she was ranked among top 2% of scientists in the field of general and internal medicine in an independent study conducted by Stanford University. She has contributed to several national and international technical assessments concerned with air quality, including the global burden of disease and comparative risk assessment, the IARC monographs, the global energy assessments, the World Health Organization air quality guidelines, and India's state level burden of disease initiatives. She is also a fellow of National Academy of Medical Sciences, India. She currently serves as a member of the National Steering Committee on Air Pollution related issues for health effects for the Ministry of Health, Government of India, and the Indian Council for Medical Research led National Task Force for Assessment of Impact of Initiative to Promote Clean Household Energy. She is recipient of many awards, including the Laureate India Research Excellence Citation Award, the Publication Health Foundation of India Award for Outstanding Scientist in Public Health, the Hari Om Bus Trust Award for Outstanding Scientist administered by University Grant Commission, Government of India, the Outstanding Women Scientist Award for the Government of Tamil Nadu, and the Award for Excellence in Environmental Health Research administered by Harvard Medical International. There are many things to say, but to keeping time in mind, with this brief introduction, I request Dr. Kalpana to start her presentation. Dr. Kalpana.
Thank you, Dr. Rastogi, Dr. Tripathi, and many of you, my colleagues. I've had the privilege of working with several members of IASTA, Dr. Tripathi and Dr. Sadnik in particular. And although I've known of Dr. Rastogi through Dr. Sachi and other mutual colleagues, it was a great pleasure to receive the invitation, Dr. Rastogi. Really appreciate your invitation. And sharing these kinds of interdisciplinary results now has become so important. Previously, aerosol scientists, rarely talk with epidemiologists to sort of learn about what exactly is happening. But the imminence of the issue at hand in terms of air quality and health certainly begs for us to be conversing more, including the nuances of our study methods, so that we can actually resonate more with each other's needs and sort of fulfill things in a way that the urgency of the situation in India demands. So thank you once again for this very privileged opportunity to share some of what my team has been engaged with over the last many years now, and in the short time that I have, I will certainly try to skip over many of the details, but I'll be happy to share publications or other kind of resources some of the younger members might want to sort of delve into more. And I want to acknowledge the very important contributions, one of your own members, Dr. Sadnik Day, in this collective effort by the group of health researchers in the field of air pollution and Dr. Tripathi as well. So many of this, is not just my team's contributions. It is a collective effort of what the evidence pool is looking in India. So that we can understand and perhaps do better to inform the NCAP in terms of strategic directions. So my talk is going to be sort of really looking more than what we have done, the sheer challenge that all of us are confronted with. India, in terms of air pollution exposures, just like any other low and middle income country, rural or urban, indoor or outdoor really don't make much of a difference in terms of where these exposures can occur or when in your life these exposures can occur. So the challenge of not just creating, if NCAP sort of really looks at attainment at some point on time, but you have to sort of really sustain these attainment areas, and they have to be seamless across rural and urban areas. So it's not enough if one part of the city or one part of a state is an attainment and the other part is not, because people are moving around and air, of course, moves around. So you end up really having a health situation in which you just have your pair of lungs that you're born with, and you end up, you can't really stop breathing. So you end up dosing yourself involuntarily throughout your life. So what do you do in that kind of a situation? How protective can you be in terms of emissions control to sort of really make a difference in this? So the pictures on either side of the panel, I don't think any one of us in our audience really needs an explanation of what this aerosol overload is doing to our population. But let me share some nuanced details. First of all, when we talk about epidemiology or the health, just like, you atmospheric scientists would sort of really look at the entire aerosol profile of a column of air to sort of really understand, what can go where and do what. We as epidemiologists and health scientists, look at what happens when a aerosol, which has a certain deposition efficiency in our lungs, what can it do? And unfortunately, fine particulate matter, as we know, and many of the gases, as we know, end up not just impacting the place where it gets deposited because of their ability to sort of really distribute throughout the body and impact it over the course of the lifetime. Now we recognize that air pollution is responsible for directly, be in the causation pathway for, multiple categories of diseases, as reflected in this most recent statement on what constitutes an adverse health effect of air pollution by the European Society, Respiratory Society, and the American Thoracic Society. So you can easily appreciate it's not about, COPD as we used to think, or it's not about asthma, or it's not about upper respiratory infections. It's not even about cardiovascular disease that we have known for some time. It's about birth impacts, high blood pressure, stroke, diabetes, and the list is just growing. And it is only a matter of time before pretty much every organ system is included, similar to what we have known to be associated with cigarette smoking. And of course, the quality of the evidence is variable, where we have really, really convincing evidence on the top part of the quadrants and emerging evidence for a whole range of adverse pregnancy, neural diseases, and metabolic disorders to be associated with just PM. And then if you can add the battery of gases and air toxics, this battery of health effects only gets larger. So how do we sort of really, tie up the emissions control and the aerosol dispersion, prevention that many of you are very familiar with an exposure benchmark in terms of where people are and what people might be inhaling and what is really important for health. And the WHO air quality guidelines that I have been very privileged to be a part of as a working group member provides us just this exposure benchmark. And those of you, many of you, I'm sure, are very closely involved with with efforts to revise the national guidelines now, national standards for PM 2.5 and other criteria air pollutants, know very well about the epidemiological basis for the WHO air quality guidelines. So currently we have the WHO air quality guidelines set at 5 micrograms per meter cube for PM 2.5, the most familiar standard that we use for criteria air pollutants, and it is down. It's half the last year's, or rather, the previously issued WHO air quality guideline level of 10 micrograms per meter cube. So, and therefore, our national standard currently, pending further revisions, of 40 micrograms of annual average PM 2.5 is even higher than the highest interim target guideline that WHO recommends here of 35 micrograms per meter cube. So we aren't even if we attain the current national ambient air quality guideline standards, we would be at a level higher than we should not ever be as per WHO. WHO recommends that everybody be at least under 35 at all times, which we are not most of the times. That's where the evidence is, and I'll just very quickly scroll through. What do we understand? Perhaps some aspects of these, attainment of air quality guidelines, or attainment of national ambient air quality standards is viewed somewhat differently by aerosol scientists or emission scientists compared to epidemiologists. So when we see numbers like this, where we are looking at, pretty much every city exceeding the national ambient air quality standards, and these exposures happening for children, happening from a variety of sources. It is the writing is already on the wall that, every organ system of every possible age group of the population and vulnerability is already being impacted. So even if you brought it down by half, and you say, our attainment has increased by 50% more compared to last year, and our attainment is, emissions have undergone a 50% reduction compared to previous years. We already know that as long as this exposure context prevails, this is something that is going to be responsible for a lot of health burden. And this is something that perhaps many of you, except for a few who have worked in rural air quality issues or household air pollution issues, do not readily appreciate, or it's not part of your working every day. Is the exposures produced by the same type of incomplete combustion that our cars do? Well, somewhat different because it's mostly biomass or other really dirty fuels that end up, producing exposures very similar to the exhaust from a tailpipe or a industrial stack, which we much more are able to model, do an emissions inventory for, and to sort of really set targets for emissions reductions. But thanks to the pioneering work of many IIT colleagues, including members of IASTA, and I'm sure Chandra Venkatraman figures in your membership list. She has published some of the most extensive emissions inventories, and Dr. Tripathi and many others sort of really modeled the chemistry and the exposure efficiency of such non-point sources of air pollution inside the home that happens every day. So one of the things that we realized, we've realized this now for quite a number of years, even before the NCAP came into the place. This, for example, is work from SAGNIC that was published in 2020, where we are looking at rural and urban exposures since 2001, based, of course, on AOD-based methods of estimating PM 2.5 exposures, very clearly documenting, and you can see the blue line here is at the old WHO air quality guideline, which was the WHO air quality guideline back then. That's 10 micrograms per meter cube at that time. And you can sort of really see that no one, rural or urban, but even back in 2001, was even close to the interim target guideline of 35 micrograms per meter cube. And unfortunately, when we look at exposure gains that have happened in the last 20 years, since 2001. In 2020, if you look at all those parts of India that are red, it just essentially means that we have increased our exposures by anywhere between 10 to 30%, pretty much in rural areas and urban areas. This is despite the increasing levels of emissions controls in the urban areas and the increasing prevalence of cleaner fuel use or LPG use in the rural areas. These kinds of exposures have not gone down. And this is yet another piece of chemical transport model-based work that Sharat Kutikunda published in 2022 that essentially provides you the same snapshot of exposure profiling, not just emissions, but exposure profiling for India across multiple states. And here is the picture in 1998, where you can see, actually about in 1998, we had about a quarter of our population, perhaps, somewhere close to the Indian annual standard or the WHO target guideline. But as to be expected with increases in population and increases in, urbanization, you have a situation where we are really shifted the distribution where literally 99% of India's population is above the WHO air quality guideline value, of course, but close to 90% is even above some of the interim target guideline values, and we have less than a third that even would meet the current national ambient air quality standards when you look into the rural areas as well. And this numbers, I'm sure you have a much better sense of what exactly is the attainment currently with the levels of control that are happening. Thanks to, again, work that Sadhnik and Dr. Tripathi have led, we now have a very good sense of which sources to control. And this entire thinking of airshed-based approaches that, it's not as though, if we end up geographically bounding the emissions control or the attainment profiles, we are going to be able to make any noticeable impact on actually the exposures because the air sheds are just gridlocked into each other, and no matter what, unless the entire airshed is addressed for the most predominant source of that airshed, you are going to be in a situation where no amount of effort done in isolated states or isolated districts is going to really yield the effect. And we now understand that residential biomass combustion is one of the very, very important sectors contributing to the airshed of the entire Indo-Gangetic plain. Of course, even in a state like Tamil Nadu, where the solid fuel prevalence is less than 30% as the primary source of cooking energy, in one of the lowest in the country, perhaps between 20 and 30%. Even there, we have rural areas that are non-compliant to the, or non-attainment, as you would sort of put it in the NCAP lingo. So one of the earliest things, even prior to NCAP, that many of us did in order to sort of move the wheel on, can we look at prioritizing sources based on the attributable health burden? Can we get better numbers? Because, understanding exposures to the extent that is needed for targeted controls is hard enough. So if you're looking at health effects, you're looking at a 10 to 20-year period before we can have tangible numbers that will provide you with the accurate health impact estimates we needed. India participated in the global burden of disease exercise, and over a 5-year period, a whole group of us, this effort was led by the Public Health Foundation of India, and Indian Council of Medical Research, Dr. Day Sagnik was a part of this group as well. And you have what we have, what we were able to provide at the time is very, very nuanced information. And the work that your membership does, IASTA does, in terms of sort of really looking at various methods of aerosol measurements, whether it is AOD-based methods, whether they are chemical transport-based methods, whether they are ground-level reference monitor-based methods, or other kinds of low-cost optical sensing methods even, although I would say that the low-cost sensor bit had not taken off in big ways back when we published these results, was to sort of really, for the first time, be able to generate state-level exposure atlases for PM2.5 exposures, which was taken as the indicator pollutant for health effects of air pollution. And as you can see, clearly the South does better than the North. But nevertheless, even in the South, you don't have situations wherein we actually are below the WHO air quality guidelines, certainly not the most recent one. And using, exposure response evidence or evidence on what might be the health impacts of this exposure on Indian populations, not just based on data gathered only from Indian populations, but by the time this burden of disease exercise had come, I will share in just a moment, we had sufficient evidence from India to believe that the shape of the exposure response or the nature of the health impacts anticipated on our population, there is no room to believe that our health impacts or the nature of it would be any different compared to any other population that is exposed to this level. Therefore, we understand, of course, there was a lot of, so these global exposure response functions sort of are applicable universally all over the world. And therefore, of course, there will be some amount of smoothing that happens when it is applied to nations or subnational territories. But we had enough evidence to sort of really look at many of the health impacts for which there was global evidence, and India evidence was looking very similar. Of course, we don't have all the types of evidence that the global burden of disease uses. So we all I'm trying to do is to sort of convince your esteemed membership that this estimate that we have produced in 2019 is actually perhaps an underestimate. It's a very conservative estimate of what do we think is the total number of deaths that could be attributable to air pollution exposures in India. And this is a very sobering reality of nearly 1.67 million deaths attributed with, you would normally think that given how quickly we are transitioning to cleaner sources of household energy, that we might actually be much lower. But unfortunately, we have a situation in which you can't wish the rural away. You can't sort of really look at the rural populations not being impacted by ambient air quality, as has been the traditional focus of NCAP on primarily cities and urban areas as attainment, red spots. We have to sort of really look at where are the rural, red flags or the red spots going forward. I will be alluding to it a little bit more, and not just premature deaths, but loss of life expectancy, as this graph portrays. This was published in Lancet Planetary Health and in the Lancet in 2019, and I'll be more than happy to share both these publications from 17 and 19. So it is very clear that the writing on the wall is, if you look at the profile of diseases that air pollution is attributable, or can be ascribed to, ischemic heart disease, COPD, stroke, lower respiratory infections, and now a growing list of lung cancer, diabetes and so forth. There seems to be virtually no difference, and understandably so from a toxicological point of view and a mechanistic point of view. If you look at what does cigarette smoke produce is, leave the nicotine out, which is responsible for the addiction. But essentially, the damage from the cigarette smoking is done by products of incomplete combustion. Products of incomplete combustion from burning biomass close to where your nose is, and that's why you end up inhaling it and you end up damaging your lungs. So if you look at many other products of incomplete combustion, it is not surprising that everything that we knew about smoking is coming to bear out in terms of air pollution. So the WHO Director General, the current Director General, designated air pollution as the new tobacco, because all it does is, the impacts at the individual level is far less, because the dose is far less compared to active tobacco smoking. But the impacts at the population level, thanks to the battle that we have fought against tobacco over the last 50 to 60 years, we don't have that many smokers. So we don't have that many people exposed. It's not about the strength of the association, but it is about the number of people at risk that makes air pollution as big a menace as tobacco smoking. So we need to sort of, you can imagine, it took us 50 years and we haven't still won, we still have some naysayers on tobacco smoking. Is probably not so harmful. I have friends who have lived to be 90 and 100 who are still smoking. And so you can imagine, for people who are naysayers for air pollution or development, or for that matter, negate the health impacts of household air pollution, dismiss it, there is no mechanistic basis for us to think that all of this, we will need, multiple actors to eliminate air pollution, similar to the tobacco use. What we have is a framework convention on tobacco control that brings in ministries of health, ministries of commerce, ministries of finance, ministries of education, and then we have been able to make a little bit of a dent, or rather quite a big dent, fortunately, on tobacco use. But if you're looking at air pollution, it's primarily, I'm so happy to be talking to a whole bunch of aerosol scientists. It's not very often that we talk to these quarters. Most of the time we epidemiologists are battling our heads on how to improve this evidence base. So you can imagine what it would take. Many of us really need to come together if we are going to win this war on air pollution, similar to what we did for tobacco use. So the unfortunate part is air pollution, just in comparison, shown here are the top 20 risk factors contributing to all kinds of ill health in India, and air pollution, clearly tops the list. The blue bars of the horizontal bar chart represent non-communicable disease burdens, and the red bars are primarily, lower respiratory infections or other, early childhood impacts. And clearly, the huge burden on non-communicable diseases from air pollution, competes with blood pressure, competes with tobacco, competes with dietary risks, competes with blood glucose. So what do you do then? Many of these risk factors are controllable, modifiable at the individual level. You can do something about what you eat, but can you do something about what you breathe? Without somebody else and many other people sort of really ensuring that, that the air is available for you to breathe, and you can't carry canisters of air. Hopefully we won't come down to that level. We are already there with water, but you can imagine when you have modifiable risk factors that are not within the Ministry of Health, to directly control through behavioral modification, through individual physician counseling, you have a huge challenge of dependencies for the Ministry of Health with other ministries that have to be responsible for the clean air actions. And when Ministry of Environment is vested with this task of clean air actions, they look to Ministry of Health and say, where is your health evidence? Where is the impact evidence? And it's not easy to, generate evidence attributable to air pollution, disengaging it from blood pressure, disengaging it from tobacco in really, really tangible ways. You have to sort of play it all together and look at relative benefits when you are doing it all together. So it really is not a very easy exercise, but we do know from all the observational epidemiology and now with randomized controlled trials that we are indeed very confident about the magnitude of the health effects. And many of the other countries where air quality has improved substantially over the last 20 to 30 years. We have had increases in life expectancy. We have decreases in non-communicable disease burdens. Looking at proof, not through RCTs like the way clinicians are used to, but through long-term observational epidemiology that has come to mind. So, so we as a team, over the last 20 years, have been looking at health effects of air pollution in India across multiple settings and multiple states. And so now, I will just provide a smattering of the consolidation of all that evidence that can be very, very helpful to sort of put a blanket around it and say what has been the evidence and experience from health effect studies in India. Why are we confident that the health effects that we are seeing is actually a tangible one? And how, but more importantly, I think people are tired of knowing that air pollution hurts you. They are all asking us, what are you doing about it? What can I do about it? And therefore, as scientists engaged in this discipline, we are needing to sort of really inform the NCAP about how can we strategize evidence, funnel evidence so that we have the ability to add impetus to ongoing and new air quality actions within the NCAP. So let me just quickly recap, over the last 20 years, what has been done by the health research community in collaboration with the exposure assessment community is, these are not devices that you all use every day. These are personal exposure monitoring devices that we have had to struggle enormously to make people wear and tag it on people and follow people throughout the day for many days in a year, for many days in a month, to really understand, where the exposures are coming, what exposures do they experience, what microenvironments can be responsible for what fractions of their exposures, and what sources can be attributed to what parts of these exposures. And while you've been looking at the world from satellites and from other kinds of reference grade monitors that end up community level profiling, when we are looking at health effects, we have to sort of somehow look at integrating these higher resolution, exposure metrics with lower resolution exposure metrics that typically satellites or other types of methods, provide. Even 1 kilometer by 1 kilometer resolution is not good enough when we look at, hyper local gradients and exposures that can really impact health of population. So one of the things that we now know very well, not just to do personal exposure monitoring. Nobody can go around wearing a monitoring 365 days in a year for 20 years in our life to know what is the day-to-day variations and space-to-space variations. We have now developed very, very good long-term exposure assessment methods. Again, I want to bring and credit the work of Professor Sagnik Day in terms of sort of really reconstructing these long-term, lower resolution methods with shorter term hyper, or high resolution methods to create exposure profiles for men, women, children, in rural areas, in urban areas, if you look at, if you want to ask us a question of what do you think is the exposure range for PM 2.5 for any of these age groups, and in many cases attributable to what sources, thanks to the work of Dr. Tripathi, we can actually pinpoint it fairly well. Where are these exposures coming from? What is the range of exposures? And then therefore, what kind of health effects can we anticipate? And here is the 1 kilometer by 1 kilometer PM 2.5 database that has been published and developed for the CPCB by colleagues in IIT Delhi, along with colleagues from CPCB, work led by Dr. Asagi Day, to sort of really look at, if we can look at 1 kilometer by 1 kilometer, epidemiology becomes a lot more feasible than when it was 100 kilometers by 100 kilometers just about 2 decades ago. But knowing exposures is not enough. We have to sort of really look at what kinds of health effects. And I'm going to zip through some of these slides, and there are many, many, many publications from all these studies which has looked at, if this is exposure, what about health? What health endpoints do we have evidence for in India amongst rural and urban populations? And here is a smattering of those health where we have tangible evidence, high quality publications providing exposure response information. And one of the things that I want to allude to about exposure response is, when you have continuous exposure and continuous response, you know that if a source reduces an exposure from point A to point B, you can actually predict what the health gains would be, rather than saying that these people who are exposed to this source are at so much greater risk than the other people who are exposed to another source. If you have continuous exposure response metrics, quantitative exposure response metrics, you end up informing air quality actions in much more tangible ways than by knowing epidemiologically that something is associated with something. You have to sort of really say, if you did something about it, what would be the health gains? And that is a nuance that we have perfected over the years in terms of how to accrue information. And here are some slides that talk about the Tamil Nadu air pollution and health effects study cohort that my team operated between 2010 and 2015. Yet another study on cardiovascular disease. I'm just scrolling through these slides. I'm not going to read all the nuances, just to give you the depth of information that is currently available to substantiate my claim that all these health effects studies have been done in India and have been published in peer-reviewed journals. And this is not only extended to the exposure assessment methods that I showed in the instruments, but using the high-resolution satellite-based information, we are now able to use population level data sets. It can't be done in individual cohort studies. Cohort may be expanding over a 10-kilometer radius, so satellites are not going to be very useful for that. But when you have a national family health survey data set that covers the entire country, it is possible to pick up associations, at least to identify hotspots for particular health endpoints where other kinds of health related interventions have gone on. So if there is an association with anemia, you can look at where has anemia programs been less successful compared to the ones that have been more successful, because after all, air pollution only predates on the underlying health condition. It increases the odds of anemia. It doesn't directly cause anemia, although some amount of mechanistic evidence is emerging that it is in the mechanistic pathway as well. So here is here's all that evidence. So what we did in the last few years, just the last 5, was to look at, can we look at, one sectoral intervention in NCAP and come out vocally and say, if you want to put all your bets on one horse, what would that be? Or what is the lowest hanging fruit for air quality actions? And many of you know the NCAP program much better than what I do. You have all been part of informing the NCAP design. And here are the sectoral interventions. And I would be very happy to note that a lot of the research done in India, including perhaps some research done by our groups, have been responsible for identifying the household sector, indoor air pollution due to dirty fuels, and addressing indoor air pollution, including clean cooking, as a sectoral intervention of the National Clean Air Program. You could have thought that it normally would not have even made to the chart, had the traditional focus been only on urban areas. Thanks to the work that has been done by the collective effort of the Indian researchers, this has been enabled. Shown here are the modeling results again from Dr. Day's group, where they clearly show that if you were to completely eliminate household sources, biomass, solid fuel reliance as a source of ambient air pollution, if you were to completely eliminate that source, you would actually be in attainment of the national ambient air quality standards in almost 80% of the country. This is at the national level. Of course, there will be, it may not be possible, in some states, including the Indo-Gangetic Plain, but just to sort of really let you understand the magnitude of benefits that can be gained by focusing our attention on this one source that we are already, addressing as a part of the National PMUY program. To our research group, it seemed like since now 99% of households in India have access to LPG, and it has, it is clearly not translated into 100% use of LPG. It can't possibly, given the economic situation. But nevertheless, if we can sort of really look at the benefits of LPG, exclusive LPG use over a short period of time, can we look at, informing the NCAP through what might happen if you enable the population to exclusively use LPG from a baseline of exclusive biomass use? What exposure reductions can you achieve? What health benefits can you really document? And so we mounted this multi-country household air pollution intervention network trial called the HAPPEN trial, the results of which are now becoming to be published in very eminent journals, including the New England Journal of Medicine and Lancet Planetary Health, where we decided that not just one country, but 4 settings where biomass is being used. We would start with baseline with biomass, randomize them to an intervention arm and a control arm, give them LPG and enable the LPG use without actually, we can't force the participants, of course, but monitor LPG stove use, and more importantly, monitor the elimination of biomass use. It's not enough if you start using LPG and your chula is also burning side by side. Exposures would be going on, and then you wouldn't find. So monitor the biomass use, monitor the LPG use, to look at whether if you use LPG exclusively and if you were to provide it entirely free, obviously not a realistic proposition, would we achieve any health benefits? And we were looking at health benefits on birth weight, child severe pneumonia, growth and stunting, and blood pressure, of which the birth weight results are now available and published. So this is the results from the multi-country HAPPEN trial. As you can see, at baseline, both are comparable to PM 2.5 exposures, personal exposures. These are maternal exposures monitored over a 6-month period. Post-intervention, the intervention was given at around 3 months duration. And you can look at the control arm being here across the 4 countries, and the intervention arm below the WHO air quality guidelines of 35 micrograms per meter cube, interim target guidelines of 35 micrograms per meter cube, which is also below the national ambient air quality standard of 40 micrograms per meter cube. This is just to say that if you were to predict what might be the exposures for rural populations if entire populations transition into LPG, sans the other sources, no open agricultural burning or any other industrial sources, we would actually be able to get the populations to be under the WHO interim target quality guidelines. We had greater than 99% LPG use because LPG use was free, and the participants really understood that if I have to continue to receive LPG for free for about 18 months till we were monitoring, they voluntarily chose to give up biomass. And so all this myth of our populations really like only the flavor of traditional foods, they won't cook with biomass. It is very difficult to convince a traditional population to transition into biomass. We did no coaching, no, sort of behavior conversion. All we did was provide LPG for free, very clearly illustrating that the economic barrier is the biggest barrier. Although we have done many other assessment studies, again, the economic barrier was coming up as the primary ones, but it was really looked at, uninterrupted supply of LPG provided free of cost. Not an economically viable proposition, but all I'm trying to say is here is one piece of information that it will get you to an exposure level where you can expect health benefits. So what health benefits did we see? This has been recently published in Lancet Planetary Health, the exposure response relationship for birth weight. The first one is for, PM 2.5. The second one is for black carbon. The third one is carbon monoxide exposures throughout pregnancy and the change in birth weight. As attractive as these slopes look, the expected impact on the birth weight was far less in these rural communities than what we had originally projected the benefit to be. Not very, very surprising, you should have thought, given that the people whom we targeted, they're the poorest of the poor, exclusive biomass users living in fairly remote communities in Tamil Nadu, where their overall population health status was very poor to do that. So you come in and intervene with LPG at about 3 months of pregnancy for a 6-month period. So you can imagine that the impact on birth weight, we are glad that we found impacts associated with lower exposures. But unfortunately, when we looked at the difference between the control arm and the experimental arm, we did not find a statistically significant difference in the birth weight. Understandably so, because the expected magnitude of exposure reduction was there, but the expected magnitude of the health effect was far less than what we had originally powered our sample size to be, and therefore, it was not a statistically significant difference, but it was in the right direction. Pointing out to the fact that when you intervene on environmental risk factors, if NCAP thinks that we will intervene with emissions control in one area of the country and expect to see health benefits, it is not going to be easy to document. We knew this somewhat straight away. That's why we picked a fertile ground and said, okay, we will make every condition ideal. No other sources of pollution, no other very low ambient air quality, background pollution, only biomass, really rural community, 100% use of LPG. Unfortunately, human body is not there only to answer a researcher question. It has to respond to multiple insults given to it at all times. So if you are thinking that a research group or a research community can come up with the evidence in the short term for impact of health benefits from NCAP intervention, I would really beg all of you eminent colleagues who are part of the NCAP to not expect to see this in very easy ways or expect us to provide that evidence in easy ways in the short term. Exposure reduction, yes, that we can document extremely well, and we can certainly look at health benefits in the right direction. And therefore, it is a long-term effort to sort of really look at health benefits. So I want to wrap up by saying the way forward is to not address environmental risk factors one at a time. every single health impact, especially for the most vulnerable amongst us. Young children, pregnant mothers, elderly, they have multiple risk factors that are going on. And if you're looking at many of these risk factors being related to poverty, the ones that are most exposed live in the most congested neighborhoods, the worst air quality. The ones that are reliant on biomass fuels for cooking also do not have access to clean drinking water, do not have access to good maternal health care. So we do have government programs that are targeting each one of these risk factors. So it is an expose-some approach that we need to take. Poverty is an inextricable element that is embedded in environmental exposures. So when we are looking at environmental exposures, to be naive and intervening at one risk factor at a time and actually expecting health benefits, when even health interventions, one vitamin supplementation at a time, one nutritional supplementation at a time, water and sanitation at a time, has not yielded us any kind of results, in a black and white kind of way for us to, but we have still gone ahead with these programs, and we have seen benefits of water and sanitation programs, even if the trials were null in India, and now look at childhood stunting, the levels are much, much lower than what it was 20 or 30 years ago. That's how long it takes for us to sort of really expect the health benefits. So therefore, believe in the science and intervene in the spirit of the precautionary principle, and to sort of really, you are all in multiple places, monitoring exposures, monitoring aerosols, monitoring, you are everywhere, monitoring, air quality, but we as health epidemiologists are not everywhere. Or rather, we don't integrate the information. We have the health information systems with your aerosol information system. So if you can really look at long-term local surveillance for exposure health, and our own group does a lot of biological monitoring for exposures as well as other kinds of early biological effects, we really need to look at, where are your NCAP action strategic points? Can we look at coming together and step up the surveillance in these sites so that we can actually provide long-term trends and actually, give you some insights on doing that, and creating capacities. I'm sure Dr. Sachi is operating multiple centers of excellence as part of the NCAP for the aerosol components of it. If we can look at leveraging these centers with other centers that may be able to have the health, the social science elements, the behavior, the economics. Perhaps it's already happening, I'm not sure, but I just wanted to sort of put in a submission saying that there is an opportunity to do this perhaps in every district of India, in addition to the already established network of institutions that you may have thought about. And then, of course, populating this information in public dashboards on an annual way, and to sort of really emulate. I think the SDG India has sort of really come a long way in terms of scorecards to sort of look at, which SDG have we done well and which SDG have we not done well, and which states have done well and which states haven't done well. So perhaps for NCAP too, we can look at emulating a scorecard. Where have you done well on exposures? Where have you done well on sectorial control? Where have you done well actually on health, or where have you documented? You don't even have to do well on health, as long as you are set up yourself to monitor health very well. That in itself is a progress towards, better actions at that level. Sort of have indicators and scorecards to evaluate the NCAP and make this available with, the academic community, the citizen science community, so that our dream of creating seamless, healthy breathing spaces is something that we can realize perhaps at least towards the end of our lifetime. I know I am not very young, and I see a lot of youngsters in the membership, so maybe they can make this a reality for us, wherein we integrate across sources, integrate across boundaries, and carry on with this mission of really creating healthy air for everyone, everywhere in India. Thank you again, Dr. Rastogi, for this wonderful opportunity. I said 35 and I'm now at an hour. Yeah, so I'm this classic professor who goes always over time. So I hope I have not exhausted all the time for questions. Thank you very much.
Thank you. Thank you so much, Dr. Kalpana. It was such a interesting and informative talk. Now I request Dr. Sagnik Day to take care of this question answer session.
Yeah, thank you, Dr. Rastagi. Thank you, ma'am, for providing such an insightful insights actually into this whole problem, as always. So we have time for now question and answer, and I see already Dr. Rastagi's hand is up. Okay, yeah, please.
Okay. Thank you. So, you have shown that air pollution is affecting us in many ways. Earlier, it used to be only cardiovascular, but now people have seen it is affecting almost whole part of our body. And we also understand that the size of aerosol, finer the size, deeper the reach, and then they can go and affect. So what I was thinking means, see, the way air pollution is affecting the body, same way can we, if we understand the mechanism properly, then can we use the medicine in the same way? And then you give the people medicine in the same way that they are going to affect you positively. Instead of negatively, they can affect you positively. And the dose will be required much less compared to whatever we are taking orally. So what is your comment on that?
Indeed, for the longest time, our understanding of drug delivery has informed the science of understanding, transport of not just air pollutants, but all kinds of toxicants, right? So we have used this understanding of deposition efficiency. In this case of air pollution, it's the lungs, but there are other toxicants that have priority deposition organs. So what affects the particular disposition of pollutant after it is deposited in the body has been the primary basis for all kinds of drug design. So we and therefore we mimic. After all, the pollutant mimics what a natural mechanism is available for deposition and distribution. And in some instances, for example, for understanding the drug delivery mechanisms for some chronic diseases, our understanding of human fine particulate matter physiology has helped, and it has worked the reverse way also. But I will say that if that is a benefit that we need to accrue from air pollution deposition in our lungs, perhaps we should not count on it, because we can actually understand the mechanisms of drug delivery now quite well through in silico modeling. We have a lot of physiologically based pharmacokinetic models that can allow us to sort of really do that and do in situ imaging or monitoring to sort of understand the mechanisms of improving drug delivery. And now personalized medicine, it's not about getting in the body to where you want to get and what you want to get, but what do you take in the first place? Why does a medicine work in you but not in me? It essentially is based on, I may take the same medicine, but does my, kidney get, what I take orally the same way that somebody else's kidney does, and why does my kidney process it differently, and so forth. There are so many personalized medicine therapies coming on that those can probably be used much more effectively than this particular route for understanding routes of distribution and impacts.
Thank you.
Yeah, thank you, ma'am. So if anyone has any question, I request them to raise the hand and I will call upon. In the meanwhile, there are questions in the chat box. So ma'am, there is a question from Shruti that what role does the public play in mitigating the emissions? Could you recommend ways through which we can educate the public about the health impacts and recommend strategies to reduce exposure?
Yes, of course, everything is in the hands of the public. When citizens decide to do a certain action, I don't think anybody can, that's the power of our democracy, right? We can have anything done if the citizens voice it. But most importantly, it's good to have responsible science be disseminated so that it can be acted upon. And therefore, the science of this is quite complicated. We are just beginning to understand it in ways to communicate without sensationalizing it, right? And without sort of, you have to realize that many impoverished communities and many vulnerable communities do not have a choice. So unless you are sort of really telling them what to do, what's the point in saying, your life is very bad, you are going to die in 20 years earlier. You have to be able to sort of say what kind of actions you can take. And if you tell them, very generic instructions, walk when, they're already walking 5 kilometers probably, and somebody else who's not, and they can't. So there are some limitations on, when you can take the evidence to the public and in what form. But I totally appreciate your, what do you call, a voluntary request for information, and this is something that the National Program on Climate Change and Human Health is already putting out in terms of information for the public. The WHO is also working with the NPCHH of the Ministry of Health and Family Welfare to provide modules for practitioners, including medical practitioners. The best ways that we have had health information disseminated to us is through our own personal physicians. If doctors can be educated, then they would be responsibly telling that. But certainly, you as a community of environmental health professionals can be also charted with some actions that can contribute towards exposure reduction. Yeah.
So, ma'am, Shruti has another question. Many recent studies have shown gas stoves emit benzene, which can accumulate indoors. Could you comment on the health impacts?
Yeah, you have to recognize that, no combustion process is entirely risk-free. And therefore, you have to have some residual, products that are harmful for the environment, for your health, and so forth. And so you can sort of really look at how much ability do you have to reduce the exposure, not the emissions. Emissions will be there. So the opportunity to reduce exposure to benzene from a gas stove through ventilation in our tropical countries is far greater than the opportunity to ventilate your kitchen to reduce PM 2.5 exposures from a biomass stove. So even if you had a turbine blowing in a kitchen, rural kitchen, you can't get the levels of PM 2.5 level low enough for health purposes. So you have to sort of really look at exposure trade-offs. And you also have to look at near-term health benefits for the entire population. Yes, of course, solar is great. Yes, of course, electricity would be even cleaner. But are we in a position to give it to the entire masses? We are not even there yet with LPG, but at least can we enable this for 20 years? It's okay. We might have a residual risk from benzene. We might have a residual risk from increased fossil fuel combustion, but can we live with that risk while we are mitigating risks worth 0.6 million premature deaths per year attributable to household air pollution? It's an exposure trade-off. Nothing comes without risk. So we have to sort of really look at, benefits of gas stove, and in my own personal assessment, what kind of a solution do we have for this particular source of air pollution that is immediately scalable and implementable? Comes the money, but if it can be part of the development package at the cost of health, this is where I would personally put my money in, not because, I research in that area, but because that has been the strength of the evidence that the collective community has generated.
I see Dr. Pandithurai has raised his hand.
Yeah, are you able to hear me? Thank you, Professor Kalpana Balakrishnan, and it's an excellent talk. So if I'm surprised to see that even the accessibility of LPG and all is great nowadays, but still we are having 29% of population having risk from indoor pollution So do we have any records in past? Because if this is the case at present, 29%, we could have been like, biofuel users could have been much higher percentage 30, 40 years back when our grandmas and mothers were cooking. So do we have the history of this kind of health hazard of indoor air pollution in the past?
Indeed, the earliest record of some of this was done way back in, well, not quite, not our grandma's generation, so to say, but certainly our mother's generation, in the 1950s and 60s, it was starting to produce some of the evidence, but most importantly, it is very hard to have imagined that such a source of pollution where economics and poverty and underdevelopment was rampant would have merited a discussion on environment, right? It's not until our development reaches a certain stage that we even begin paying attention to the environment, and environmental health is even worse. So what changed in the last 20 years, I think, is the technology, and actually this is such a insult that many of the devices that were supposed to measure personal exposures to urban air pollution and the urban air quality settings would actually shut down within 2 hours of operation because the filter would get overloaded. Such is the insult. So, people didn't even have proper instrumentation to sort of really measure what these exposures are and to sort of really understand that, that these exposures are happening. But what was very well known is that, the percentage of fuel use has declined, of primary solid fuel use has declined from about 90% in the 1990 census to about 50% right now all over the country. The 30% contribution from household air pollution to PM 2.5 is a contribution to ambient PM 2.5 from household solid fuel use. And so this probably was also much larger back then, except that even now we don't have rural ambient air quality monitoring, right? It's the satellite-based methods that have allowed us to really pick out the gradients very much. And so we are beginning to understand the rural gradients now with much better precision right now, but health as well as fuel use records have been available for almost 40 years now.
Thank you, ma'am. Thank you.
So, ma'am, there's a question that while setting the air quality guideline, does WHO consider climate impacts as well? And on a related note, there is another question that when it comes to health burden, can we estimate the combined health impacts from multiple environmental risk factors along with air pollution exposure?
Excellent question. Yeah, I wish we could. Unfortunately, our methods for counting is not sophisticated enough to do multiple risk factors altogether. So there is double counting. There is no question. So when you intervene on a particular risk, you will have some benefits for the other risk factors as well. So you can't really do them, totally independently. And what was the first question?
First question, ma'am, was that does WHO consider climate impacts on health as well?
No, the WHO air quality guidelines is specifically with respect to the epidemiological evidence gained from human exposures wherever they are available in the world for specific health endpoints. Even if something was climate helpful from a particular standpoint, if it was it was harmful from an exposure point of view, it would not be taken into account. So it was all exclusively. We do identify opportunities for health co-benefits, but from climate, but those are not fed back. Although I agree that if we were to look at emissions leading to climate and then climate change in adding to the health impacts from a certain emission and a certain exposure, then that would be great. But that's still several years down the line.
There's a question, not a question, rather a comment from Dr. Bhatti that he feels that burning activities of all types eventually lead to disaster. And he has a question also that what is the ideal software or tools for this kind of epidemiological studies?
Well, I don't think we have an ideal tool, but we do have, in fact, just because of participation in this lecture, I could not participate on the simultaneous product launch that RTI, for those of you who are nuanced enough to look at, so RTI has launched a health impact assessment tool now for NCAP, and I'm told Maureen Cropper, who's one of the very senior economists at the World Bank, is leading this exercise. So for some of us who are, nuanced health impact researchers, this tool may be useful, but for the average early career research, there is no software that I know that you can do for an epi study, but there are several SOPs that have been written for these cohort studies now. Study protocols have been published, so perhaps those can be used as ready reckoners for how to sort of really mount these studies. But software for health impact assessment, including BenMap and many other tools that the WHO provides, AirQ Plus, I guess, so these are all tools that can be used and accessed for health impact assessment. That is, if you know an exposure, then it will allow you to calculate what the health impact is, provided you have information on other input parameters.
Okay, thank you, ma'am. I see Dr. Devara has raised his hand. Dr. Devara.
Thank you very much, Professor Kalpana, for an excellent talk. In fact, I have two small clarifications which I would like to know from you. One is, what is our present level of understanding about the contributions of satellites to human health problems? That's number one. Number two is, can we do, if not present, even after a little time, can we attribute a particular group of our individual pollutant relates to a particular disease? Can we go to that extent after doing all this type of cohort studies or individual studies? So these are my two long-standing questions. One is the level of understanding about the human health problems from satellite data, except the forthcoming satellites like Maya and all. Of course, myself and Dr. Saganik, we are doing collaborative program with universities like Mary University and all. But I just wanted to know what sort of, because satellites give many more parameters, of course, n number of parameters, but about we come to the human health parameters, of course, still there is a big question. So can we, what is your opinion about how long it will take to utilize fully the satellite data about the human health problems directly?
Yeah. Yes. No, I would say that, the use of satellite-based data has revolutionized our health impact methods in unprecedented ways over the last 20 years. And this is because, we have had methods of ground truthing the satellite data that was not available even some 10, 20 years ago. And while we may argue that the level of ground truthing that is happening is still inadequate, the proof of the pudding for health effects is, if it allows us to use it for health improvements through emissions control, if it is good enough on a relative scale, what I mean, it will probably not be very accurate in terms of, biases that may be underlying this thing. But what we need is, does it have the potential to inform public health? And therefore, if you look at what the other trade-off is, can we really afford ground level monitoring throughout the world in all countries? That's clearly not possible. Can we really afford high resolution information even in rich countries at the level? No, given all these ground realities, despite the limitations that satellite provide, I would say the satellite-based methods are the lowest cost sensors that we have, that we can use right now, even much better than the low-cost sensors that is coming up right now, because it's not easy to do any of these methods. So while Maya and other kinds of health-based products that the satellites will produce will be extremely useful. It is already, the entire GBD methods are premised on the satellite-based data together with chemical transport models and the ground level reference monitoring network. So I would say that, we are very thankful that you as a satellite community have produced the exposure estimates for health purposes. And this is very usable with the demographic data at large scale. It is not useful for individual actions, but it is very helpful for public health actions. And the second thing is, I don't think we'll ever get to a stage of this pollutant, this effect, this pollutant, that effect, because, after all, it's like, your body gets pleasure from, eating different types of sweets, and the body gets damaged by different types of sweets. Sweet in any form is bad, or at least bad for many people. So pollutant in any form, whether it comes in the form of carbon monoxide that produces, hypoxia, or whether it is some other, air toxic that produces the same hypoxia, the mechanisms might be similar. So as long as the insults are similar, it is not going to be possible to tease out, because they also don't occur in isolation in nature, right? They always are a bundle of it's a cocktail. So mixtures, is a huge task in environmental epidemiology. But that's the only piece we have. But we usually try to identify an indicator of the mixture, but that best allows us to reduce exposures to the cocktail. So if we reduce PM 2.5, we can be pretty sure that we are, in most instances, we'll be reducing NOx, and in many instances, we will be reducing VOCs and so forth. So you have to sort of really use the knowledge of chemistry to sort of really look at, where might you be able to pick a indicator pollutant, so that you can sort of be using that indicator pollutant and assume that we can't tell whether it is which species of the PM 2.5 is really causing all of this. We already know that, whether it is the adsorbed PAHs or whether it is the adsorbed air toxics, those are really responsible for many of these effects, but it's kind of hard to tease it out at this point.
Why I think this aspect, if you look at the literature, say for example, dust main disease what anybody can expect is that respiration problems, mainly asthma, respiration, this type of. But you see, similarly for PAH, directly one minds about the lung cancer. So this may be dominant characteristic. I'm not telling that this is the only pollutant causing this type of disease. At least a group of pollutants together, will we be able to equate in future? These are the constituents cause this type of disease. Can we make?
Yes, in fact, that is the premise with which WHO air quality guidelines have been developed, not just for criteria air pollutants. There's also guidelines for air toxics, including in our standards, and that is premised on studies that have shown the predominant moiety in the air pollutant cocktail responsible for specific health effects. And therefore, only where we don't have, individually speciated information is when we take these composite indicators of fine particulate matter or dust even to do that. Yeah.
Thank you very much. Thank you for the organizers also.
Okay, so I don't see any raised hand, but there are 3 interesting questions, ma'am, in the chat box, and I will pose it one by one. So the first question is about, lack of a proper way to document health data, particularly in the government hospitals and all these things. So the question is basically that, what interventions can be, made to really improve the health data documentation process in India?
Yeah, well, I wish I had an answer. Yeah, but except to say that the health data documentation has come a long way in terms of being electronically captured. And what is perhaps needs to improve is the accessibility to the community of researchers. It is certainly as accessible to the policy community or to the public health networks for their own internal surveillance, but it is not in a shape where it can be accessed by an average researcher, and de-identified information can be shared very easily with the research community. So I think pretty much everywhere, even if it is not, the data is not collected digitally at the OPD level, the monthly statistics of every hospital is fed into the directorates of public health electronically. So, you might not have how many low birth weight babies are happening in the primary healthcare center entered digitally. But if you go to the primary healthcare center, there will be a blackboard in which it will be written, how many low birth weight babies were born in the month of June or July. And at the end of the month, they will enter it electronically. So you can get aggregate electronic data and even granular electronic data. And so the surveillance mechanism has been set up, but the access for surveillance data has to be increased. And therefore, so that we can have more communities of researchers access this data with de-identified information and actually mine the data for association with health effects. As much as surveillance needs to be stepped up, I would say that integration of health surveillance data with environmental surveillance data is a bigger challenge than actually generating environmental surveillance or health surveillance data for the country.
There is a question which I will slightly rephrase. I think the question is basically that how important is it really to spend resources in strengthening health infrastructure to minimize the burden? And I think from where this question is coming, because we all know that air pollution burden in GBD framework depends also on the baseline mortality and all.
Yep, indeed. So this is we really shouldn't be expecting any difference from our air pollution interventions unless the physical activity group gets its act together, unless the cholesterol group gets its act together, unless the salt group gets its act together. So we really should be talking at the same table, doing that. And you can imagine in the GBD group, the air pollution, those of us in the air pollution group, we had 5 studies, and the salt group will come with 500 studies, So it was a huge task for us to even persuade that, look, air pollution, look at the strength of evidence, please get it on the table to even rank. So even with this very limited positive evidence, it was like staring at our face, we never imagined that the numbers will come out to be. When we ran the model, that's how big it was to do that. But I agree, you cannot expect that isolated environmental interventions will have any effect. Just like I know all modifiable risk factors must be acted upon in holistic ways to impact health in the best possible way.
I think last question from the chat box that I can see also is very interesting, ma'am. So the question is that in the non-LPG era, when most of our earlier generation used to cook with biomass, is there any chance of impacting their genes? And then that impact will be passed on to the current generation.
Sorry, say that again. Cooking with biomass can have genetic impacts?
Yes.
Or mutations? Yes, of course. We do know that household air pollution is is likely to be a human carcinogen. And, when you have products of incomplete combustion from household air pollution that includes PAHs, that includes all kinds of, well-known combustion products that are known carcinogens, you can expect that some of these carcinogenic endpoints, do cause mutations, and what might be the, what type of mutations do they cause, and are these inherited mutations or likely to sort of to alter the the epigenetic environment in such a way that it can be carried forth for the next generation is something that is being researched upon. But yes, it does. Many of the carcinogenic endpoints are mediated through the interaction of these air pollutants with our DNA.
Okay, I don't see any more questions, and also I don't see any more raised hand. Ma'am, I just have one question from my end before I finish the Q&A session. I could not resist. Since we are now revising our national ambient air quality standard, so what would be your quick advice to the CPCB, given that now we have really a very good indigenous health evidence, if I may say so?
I would say do not revise. Let's just implement what we have. We have very good evidence why implementing the current standard makes sense. We were not so sure last time around. Now we have very good evidence. Let's just implement the current standard and reach complete attainment. Then we can worry about revising has such a, I don't know, maybe I'm naive, but this would, to me, it seems like, what is different between last time and this time was last time the health evidence was weak, scant, not persuasive, not coherent with the global evidence. Now we have all of that. Let's just go ahead with implementing, put all our energies in getting 100% attainment with the current NCAP. Then we can worry about revising.
Yeah, very good point, ma'am. I think we come to the end of the Q&A session, and I hand it over to Dr. Rastogi. Is he here?
I don't think he's here, so you can now.
Okay, I think let me then give the vote of thanks and on behalf of IASTA and on my personal behalf, I sincerely thank Professor Kalpana Balakrishnan for sparing her time for this wonderful talk. It's always a pleasure to listen to you, ma'am. And I just want to mention to everyone present here that to promote air pollution epidemiological research in the country, CAFR India network has been created, and ma'am is one of the advisory board member of that network. And I think IASTA and CAFR India can definitely work hand in hand in further, take the research forward. And I also want to take this opportunity to thank all the attendees. If any attendee is not IASTA member, I would sincerely request them to become part of IASTA and get benefit. Tune in for the next monthly lecture. And I thank all the IASTA President, Professor Tripathi, Vice President, Dr. Rastogi, Executive Council members, Manish, everyone, the ex-president of IASTA, Dr. Devara, everyone else who has been contributing to this particular field. And with this, I think let's call it a day. Thank you, everyone, for spending your time.
Thank you.
Thank you, sir. Thank you.
Thank you, madam. Thank you.
Thank you.